Okay, to this lecture, this class, these sets of assignments for today, we're shifting a little bit away now from health policy and the politics and health insurance and public health, and we're looking at how medical care is delivered, how it's organized, and how it goes from providers to recipients, and some big trends with that in the United States over the last decade. Before we get to that, real quick, and this is part of it, is a thing called the Dartmouth Atlas. And if you study health policy, it's just something that you get introduced to and you're like, wow, this is fascinating. And I'll tell you in a nutshell what the Dartmouth Atlas is. It's right here, the epidemiology of healthcare and medical services. In other words, you might think that how much cancer treatment is given is a function solely of how much cancer varies. And there is variation in cancer per capita across, there's variation on every dependent variable that you can imagine in healthcare. The Dartmouth Atlas measures that variation and then the things that contribute to that variation. And this is the guy, John Wemberg, Dr. John Wemberg, is the doctor who back in the 1970s started the Dartmouth Atlas. And he had the coolest hypothesis that turned out to be wrong, but that's cool. It's fun to find your hypothesis wrong when you find something even more interesting. He was sort of sent out, I think, by the National Institute of Medicine from Johns Hopkins in the early 1970s with the hypothesis that it was rural, isolated places in the country that were getting underserved and underprovided healthcare, and that you had to live sort of near a big urban center, metropolitan area with a teaching hospital to be getting in the 1970s, late 60s, early 70s, modern medicine. So the hypothesis was that if you didn't live there, then you were underserved. So he went up to Vermont to test this because there's a couple of urban metropolitan areas like Burlington and Vermont, but there's a lot of rural areas. And then Vermont allows you to control for all the independent variables because it's like one homogeneous, one zip code. It's very, very similar from top to bottom. And then you could see if any of the variation of the dependent variable, how many tonsillectomies, how many appendectomies, is a function of either rural or urban. Well, guess what? What he found was that, yes, there was a ton of variation in tonsillectomies per capita and hysterectomies per capita, but it didn't really have anything to do with whether or not you lived in an urban or rural area. What he found out was so much more interesting. And the thing that got his attention was tonsillectomies. And whenever I ask a class, how many have had their tonsils taken out? Maybe it's like 5 or 10% now. You know, a generation or two ago, it was 20%. Before that, it was 30 or 40%. What we found out over the last couple of generations is that most tonsillectomies don't do any good. They're just sort of pointless. And they do pose a small risk. So why do them if they don't help that much and if there's risk? When he did his initial study, he found this little town. You can go on Google Earth and type in Morrisville, Vermont. It's kind of fun. It goes shooting down there. Boom. And little old Morrisville, which is, a 5 light town. I'm just hedging. It might even be a 1 light town. Morrisville had 75% tonsillectomy. And nothing explained that. Nothing made sense of that because it was a super, super high rate of tonsillectomies. And why would you ever have a 75% tonsillectomy rate anywhere, much less in a really small town? So he went into Morrisville kind of trying to figure out, was there something in the water? Was there something, was there a plant? Like anything, what would explain why 3/4 of the kids in Morrisville had their tonsils taken out? Well, he ruled out all the sort of environmental explanations. And then he went to just do the next logical thing. He went and interviewed the doctor, the pediatrician who did the tonsillectomies, the pediatric, I forget the ear, nose, and throat, but the guy who sort of triggered it all, the pediatrician who diagnosed, and the surgeon who did the procedures. And what he found was there was basically one doctor who did the tonsillectomies. And when he asked him why you're doing so many tonsillectomies, A, he didn't know he was doing a whole lot. And B, he said, the way I was trained a long, long time ago, he was an older doctor. He said, the way I was trained was like 1 or 2 ear infections and you do a tonsillectomy. And that's when Dr. Wenberg said, oh my goodness, that's changed. You need to have a lot more now to trigger that. And for Dr. Wenberg, he was like, holy cow. If you're a kid living in Morrisville, you don't know that. If you're a parent living in Morrisville with a child, you don't know that. And that hence in healthcare, geography is destiny. Where you live in Morrisville, you're a kid, you're having your tonsils taken out. If you live in Brattleboro, you're probably not. And the minute they told the doctor there that he was like the biggest tonsillectomy doctor in the state, he quickly adjusted and got down to 10% the following year. This dovetailed with one of the most famous articles ever published on healthcare and how do patients figure out what to do when their doctor tells them to do something. And it was done by Kenneth Arrow, famous economist. And he brought this term information asymmetry to healthcare. And he realized that some markets, the consumer has as much information as anyone else and can make a very informed decision on their own. Other areas like healthcare, you don't know healthcare. I don't know medicine. I didn't go to medical school. So I depend on the doctors and I do what they say. And if the doctors say do the tonsillectomy because that's the way they were trained, they don't say that. But if they say do this or that, more often than not, we just do it because there's a gulf between what they know and what we know. And that gulf means that you're going to see a lot of variation in all kinds of ways in healthcare. And sometimes it's going to make sense when you look at it and you're like, oh, okay. There are racial disparities in health outcomes and cancer rates. When you look at the environment that African Americans often live in with redlined neighborhoods, it makes sense. They live in the least healthy parts of many urban areas. Other things like tonsillectomies, you'll be puzzled at first, like what? And then you realize, oh, it's the doctor's training, or it's the number of hospital beds, or it's how much equipment is in that area. And once you start seeing things through this lens, you realize we don't have one US healthcare system. We have 306 healthcare systems. And each of these lines is drawn based on two things: population density, which is why Kansas has this massive one here because nobody's living there. And then it's where do people travel to get their healthcare? And they sort of stay within these boundaries. They've drawn these very, very carefully based on looking at the data of where do people travel. And at a certain point, you won't go over here if you live in this region. Here, we're here in Richmond. I will work my way up and around here for healthcare, but I'm not going to go down to Southwest Virginia, and I'm not going to go to Boston, and I'm not going to go to DC. So these regions allow you to compare sort of, with some limitations. They allow you to compare apples to apples to apples to apples all across the country. And just as an example for a lot of students who are watching this, you probably come from these areas. There's Camden, New Jersey, there's Philadelphia region, there's Allentown, there's Long Island, New York's its own. There's the Boston region, the Hartford region, Providence, Worcester, Springfield, Western Mass, Albany, upstate New York. And these regions have sort of their own, I wouldn't say culture, but they have you can compare them. You can compare anything. Number of Medicare visits to hospice in Albany per capita versus Manchester. And whenever you can start comparing per capita rates regionally, fascinating things pop out. You can even do it, not even by region, you can do it by teaching hospital. 77 best teaching hospitals in the United States. And you look at one dependent variable, average number of physician visits per patient in the last 6 months of their life. They have this, all these patients are old, all these patients, because they're on Medicare, all of them have the same health insurance to cover them. But if you go to NYU or Cedars-Sinai in Los Angeles, you're going to have 3 times or 2 times as many physician visits as UCSF in San Francisco and Stanford. And that kind of variation starts making you think, what's going on? And you might think, well, maybe the people are just sicker in LA and New York than they are in San Francisco. And this graph shows to a point there is some regional variation. Each one of these dots is one of those 306 referral regions in the country. And this is the rate of hip fracture per capita. There is some variation. There are some places in the country that have more people having hip fractures. There's other places that have very little. And then there's just, that's an anomaly. Maybe it's Honolulu, nobody falls down. So the underlying variation in healthcare needs and healthcare disease and conditions, there is some variation, but there's 2, 3, 4-fold more variation in just what is done to people, which tells you that medicine is not always a science, it's an art. You can have 10 doctors look at your knee and 5 will say surgery and 5 other ones will say no surgery, do other things. And they're not necessarily wrong, they just have a difference of opinion. And this is also borne out when you look at things like discharge for hip fracture. And then you look on the x-axis, how many hospital beds per capita? So do you live in these little dots here are parts of the country where there's a lot of hospital beds per capita. These red dots are little parts of the country where there are not many hospital beds per capita. Guess what? If you live in an area with few hospital beds or a lot of hospital beds, it has no impact on the number of discharges for hip fracture, which makes sense because you only get discharged from the hospital when you've had a hip fracture. You get discharged for hip fracture when you fractured your hip. And whether or not there's a lot of hospital beds or no hospital beds, there's no variation. But for a lot of areas in medicine, whether or not to admit you and then to discharge you from the hospital for a lot of conditions is arbitrary and subjective. And if you live in places that have a lot more hospital beds, lo and behold, a lot more discharges. Now, you want to assume that maybe these are sicker places, places that need to have people in the hospital more, and hence they have more discharges. Nah, the evidence is not hugely supportive of that. It's called Romer's Law, and it says if you build a hospital bed, no matter what, eventually it gets filled because it's like a hotel bed. If you build hospital beds and you don't fill them, then you've wasted a ton of money. You see this not so much in hospital beds, although you do see it there. Where you really see it is things like diagnostic imaging. So all of a sudden you have a place that has a lot of MRI machines per capita. Guess what? All of a sudden people are getting a lot of MRIs because dang it, you bought the machine, and every time you hit the button, ding, you charge $1,000. If I had $1,000 charging machine in my house or my office at school, would I be tempted to hit it every time a student came in? Yes, I would. And I would like to think I would not do it, but I would be tempted to do it. And guess what? Parts of the country where there's less regulation on how many entities can have MRI machines, and places where there's old people who are affluent, look at this. That's where you get a lot of imaging. Which brought us to the article of Overkill by Atul Gawande, who said that temptation for over provision is a real problem. Now, sometimes the over provision is they're trying to get some more information. And you read the Rosenbaum article that said, hey, don't vilify the clinicians. Sometimes they're just trying to get more information because there's uncertainty in medical care. And that's true. But let me tell you, in the healthcare sector, healthcare is also a business. And if you treat healthcare like a business, then over provision is a natural thing, especially for older people, which is why this article is a great story because it says you can flip that and you can have primary care entities like WellMed, whose whole business model is providing primary care and getting rewarded for keeping people healthy. And lo and behold, look at the places where Medicare spending per capita is really high. Now, these are sort of, some of these places are really unhealthy, so that's going to happen more. But Pittsburgh is not overly unhealthy. If you look at all the this is low spending regions of the country of Medicare spending per capita, and red's high spending. Well, in the red areas, you tend to have more of everything, more teaching hospitals, more specialists, more big hospitals. In the areas that are low spending, there's only one thing you have more per capita than the red places, and that's family practitioners, GPs, which suggests that if you have a lot of prevention-oriented primary care, public health mission-driven doctors whose whole thing is to keep you healthy, and there's more of them per capita, then you have healthier, less healthcare spending regions. Okay, so pause for a second. Boy, is healthcare complicated. Man, is it complex and mind-numbingly difficult. Although I hope at this point in the class, you're like, I'm starting to get this. This is cool. But there's actually one really simple equation. National health expenditures. How much do you spend? How much do we spend each year on healthcare is a function of three things. It's how many people are in the system. You can break that up by public and private, but just total. How many number of people are in the health? How many patients are there? How many people who get care exist? How many are there? How much care do they get, the volume? And then how much does that volume cost? Multiply those together, the prices for the volume of care given to X number of people, and you've got your national health expenditures. Why is this important? Because if you want to restrain the rate of cost growth, you've got three levers you can pull. You can limit the number of people, which is what a lot of other healthcare countries do to limit their spendings. They just put you in a queue and say, okay, you'll get the hip replacement, but you'll get it next year. Or you limit the volume. You can say you can't have everything. You can only have these things, which is unpopular. The most common one is you just change the price and you lower the price to try to restrain cost growth. And then guys, click on this. Click on this. I don't have time to show it to you in this. This is one of my heroes. This is a totally different approach to making healthcare more available. It's not Obamacare. It's not government policy. It's business. And Dr. Devi Shetty is known as the Henry Ford of heart surgery in India. He runs his hospital 7 days a week, 18 hours a day. He has tremendously high quality outcomes at low cost because they get so darn good at it. And if all you do is heart procedures, you get really efficient at it. This is the hernia hospital in Ontario, Canada, called the Schultes Hernia Center. If I ever need a hernia procedure, I'm going there. That's all they do. And they are the best at it because that's all they do. And if you get focused factories in healthcare, just like if you just specialize in making widgets, then you get good at it and you lower the price. Which is also why I had you guys read another model of healthcare, which is, let's learn from these chains that have sort of figured out how to provide good quality food at low cost and then replicate and scale it. And by the way, love Gawande's writings. I'm sure you can tell that in this class. And when he wrote about the Cheesecake Factory, guess, this is our daughter, Allie, guess who was the first to go out and experience what he was writing about? We have one of these out in the West End of Richmond and loved it. All right, so how are we going to get these costs down in healthcare? How are we going to improve quality? One suggestion is to get rid of fee for service. Just pay physicians a salary. You want to get a fight going, go hang out with some physicians and ask them if they would be willing to take a salary instead of fee for service. Some doctors will love it. Other doctors will think it's socialist, and it'll be a big brouhaha. You'll be entertained. Under fee for service, there's no risk to doctors. They just provide everything they do, they get paid for. The hospitals get paid fee for service. They can't lose money. The risk is all to the people who pay. As you move down to these two other ones, bundled payments and capitation, a bundled payment says, look, we're not going to itemize the bill on the knee replacement. It's one lump sum. And if you make mistakes and the patient has to come back, then you're on the hook for paying for all of that. It's all bundled into one cost. Capitation is the riskiest of all, and it's the coolest. Kaiser Permanente does this. Capitation says, we're not going to charge you a nickel and dime anything. We're going to charge you one flat gym membership, country club membership, and we'll cover your family for one lump sum. Anything they need that year, Kaiser Permanente will take care of it. That incentivizes Kaiser to get you healthy because they don't want to spend money on you. And it means that they're looking out after you a lot more. Geisinger in Pennsylvania pioneered the bundle payment for heart surgery. And when they did that, it incentivized them to get all these quality and safety measures improved, because if they set a price at which they're going to make a profit or at least make a surplus, and they keep doing well, and they can bring the cost down underneath that lump sum, boom, then they're making money. If they screw up and there's complications and there's problems, then they lose money, which is also kind of what, actually that's bundle payments. Kaiser Permanente's capitation is sort of what UPMC is doing in Western Pennsylvania. UPMC is the University of Pittsburgh Medical Center. It's a massive, massive, sprawling medical industrial complex of every single thing you would need in medicine. And guess what? They sell their own insurance to their own providers. And when they do that, you're basically joining a club. You're saying, well, I'm going to buy a cheap insurance policy, cheaper UPMC health insurance policy, and it's affordable because I have to stay within the UPMC system. So they sell insurance to their own doctors and hospitals and nurses and their own medical provision. Kind of brilliant. It's all one-stop shopping. It's like a big Amazon of healthcare. Kaiser Permanente in the West Coast, a little bit in the East Coast, is like, again, a big old country club. You buy a membership per family per year, and they cover everything for you. And what's the point of all of this stuff? Is that these entities are getting bigger and bigger and bigger because they don't want to be Tower Records, Blockbuster, or Borders. These guys are all gone because they didn't keep up and they got small and they got run out. They got run out by new innovators who got big and got bigger scale. And that's what's happening in the healthcare industry. Doctors used to have their own practices and they would sort of partner with hospitals. And now hospitals and health systems are sort of buying them out. Although I will tell you, in the most recent year or two, that has stalled. That trend of just doctors selling their practices to the hospitals has definitely flattened out because doctors have realized that when they sell out, they lose control, and then they have to do what they're told. They don't like that. But along the way, a lot of hospitals have merged to get as big as they can. And you would think that they would follow that model of doing better quality like Cheesecake Factory, but the data suggests that there's no improvement in quality when hospitals merge. The only thing that changes is that their fees go up and doctors' fees stay flat. So it's about business. And it's going on. It's like Game of Thrones in the healthcare system. Hospital giants are buying each other and merging with each other to get as big as they can. Health insurers are consolidating and they're merging so they can get as big as they can. And sometimes it's even getting bigger than that. CVS is getting involved with Aetna. So you have a big pharmacy company merging with a health insurer. Cigna's buying Express Scripts, which is a health insurer, buys a pharmaceutical delivery mechanism. Walgreens and Humana are together. Walgreens is a pharmacy. Humana is a health insurer. And this is called the Big Med. It's just like other areas of the economy. It's like big companies, big Amazon, big chains, Target, Starbucks, everything getting as big as it can, because then when you get scale, you get to like run the show, and you can drive out the smaller entities. Now, what's the only thing doctors can do to avoid sort of getting absorbed by all these big hospital systems? Well, the answer is to form the biggest single specialty groups they can. All the pediatricians in one town, all the OBGYNs, all the orthopedic surgeons, all the cardiologists. And that's what you see in Virginia. And you can see the surgical subspecialties, OBGYN, internal medicine. That's how they're staying independent. Doctor owner run, not selling out. But as you get down to these other ones, they're getting more and more bought out by hospitals. And you can see just look at the data by who's staying independent and who's sort of having to kind of sell out to the big hospital systems. Now, if you ask George Halverson, who used to run Kaiser, how do you keep costs down? Like, what's the one magical thing? Since you guys are on the hook for all of a family or an individual's healthcare, what do you do to keep the costs down? And he said, keep people out of the hospital as much as possible when they don't need to be in the hospital. And if you want to read about a cool experiment that proves this, Health Quality Partners in Doylestown, Pennsylvania, did an experiment, and they competed against Hospice of the Valley, Mercy Medical Center, WashU in St. Louis, and some four other and then all the four programs were combined. And they said, who can keep Medicare patients healthier so they don't die as much and keep costs down? And only one could do it. Health Quality Partners hired a bunch of nurses. They didn't buy expensive medical equipment. They didn't get new pharmaceuticals. They didn't build a hospital. They hired a bunch of nurses for all of their Medicare patients and sent them out on home visits week after week after week. And guess what? It improved their mental health. It made them more compliant with their health regimen and what they were supposed to be doing. Because this is a great lesson. Care for people, check in on people, encourage people, and guess what? They'll be healthier. They'll live healthier, just to not disappoint their nurses. And then the costs go down, percent difference in cost, 21.5% reduction in costs, and less death, right? Pretty cool. And that's the heroism of incremental care. You guys read about this. Who's that guy again? Atul Gawande, showing how all the glory and all the television shows go to all the ER stuff and Grey's Anatomy, but it's really the non-glamorous stuff, primary care, prevention, nursing. That's the stuff. And look at this, all the high-end stuff gets all the glory and all the fame and all the money. And look, we need these specialties, but we need these even more if you want to get more value for your healthcare spending. Primary care gets paid half as much, but done right and done well, they keep you healthier and keep you from needing this stuff less. And that's, if you want to, I actually kind of looked up, he talks at the end of his article about how a surgeon saved his son's life when he was born with a heart defect. But then it was primary care clinicians for 18 years that helped his son get really well and go to college when no one thought he could. And I looked him up on Facebook. I didn't friend him. I didn't stalk him. I wasn't creepy. I just wanted to see, and sure enough, he graduated from college. Read this. It's one of my favorite quotes from Atul Gawande. I won't read it for you, but it's just awesome. And then, by the way, a little shout out to all my nurses out there and pre-nursing students. We love our doctors, but guess who we love even more? Every year in the Gallup poll, nurses rate the highest for honesty and ethics. Doctors are third. Engineers second. Hey, look at us college teachers. We used to be really low and we're coming up. So look out, dentists, pharmacists, police officers, they're going down right now. Sorry, police officers, stop killing Black people. That's just one in Minneapolis, I know. But come on, you gotta be more careful. That's horrible. And then these are, I'll just leave those. You can see what that's doing. Now, how inequality harms societies. It's too much inequality. You're seeing it right now in our country. It's dangerous. And it creates a lot of tension and conflict. And then if you look at the United States, well, where are the real inequalities? Well, they're all over the place. And then one place in particular, this deep South, Mississippi. Oh my gosh, look at these health statistics. Mississippi is at the very bottom. I always tell my students, you don't have to go to some remote part of the planet to do humanitarian medicine. You can just go to Mississippi. That'll be plenty fine. Those 306 hospital referral regions, where are the places that are the unhealthiest in the South, and especially Mississippi. And that's where, the South is where there's very little social mobility. Poor people who are born poor stay poor. Rich people who are rich stay rich. We think HIV is an urban thing. That's 2 decades ago. HIV now is in the deep South, Mississippi Delta, the Bible Belt, Florida, Mississippi. HIV diagnoses, look at that, in the South. Obesity rates highest in the South in Mississippi. Food stamps highest in the South in Mississippi. Infant mortality rates highest in the South in Mississippi. Diabetes rates highest in the South. Trump land and Mississippi. Oh, it just now I feel like I'm picking on Mississippi, but every state's got some things it's got to deal with. So you guys can see what's the biggest problem in your state. And then along comes Dr. Shirley, a doctor in Mississippi who could have left and made a lot of money and been, just forgotten with his roots and left it all behind. And that'd be tempting because Mississippi, you saw the stats. Maybe you want to go someplace else. Maybe you want to go to Atlanta. He stayed and built this really cool health system called Health Connect. That's the same thing as the Health Quality Partners. It goes door to door, regularly checks on people in Jackson, Mississippi, and catches things like, oh, your pharmaceuticals ran out 2 days before the end of the month. Let's get that refilled, or you're going to have a big condition. Or your utility bill didn't get paid, and they're going to turn off the gas and light and water. That's going to cause a huge downstream problem, and you're going to be in the ER. Let's not let that happen. And it's like a mix of social work and primary care and prevention and checking in on people, and it saves a ton of money and you get better health outcomes. Brilliant. One of my heroes, Dr. Aaron Shirley, passed away in 2014, but never forgotten. Inspiration and awesome. Take care. See you guys next class. Bye.